So we know that a lot of infectious disease is seasonal, winter flu epidemics, colds in winter. There's a strong seasonality to many infectious diseases. And when COVID first came along, there's a strong seasonality to many non-infectious diseases too, which we'll move on to, cardiovascular disease in particular. But our hospitals are busier in winter than summer, markedly busier in winter than summer. And we just shrug our shoulders and say, yeah, it's winter, without thinking, why are our hospitals busier in winter than summer? But I'll move on to that later. But heading back to infectious disease. So I was wondering if COVID would be seasonal like influenza is, a respiratory airborne disease. And of course, at the beginning, you need 12 months to see seasonality. And at the beginning, oh God, I'll have to wait a year, maybe 2 years, so the data's more robust. But we realized early on that Johns Hopkins started collating all the data on COVID deaths within America. So America is 50 states, but it's 3,200 counties. And the great thing about America is it covers a huge geographical span. It's the top to bottom is a long way, and very different UV environments. And Johns Hopkins was putting out on its COVID research database at county level COVID deaths within America. So these fantastic data sets. And I previously, with my cardiovascular work, had been looking at the epidemiology of heart disease and sunlight, stuff we'll move on to later. So I've been working with mathematical geographers who are very good using satellite data, NOAA. I mean, all these amazing American institutions we use, and thank you to the American taxpayer for providing them. So anyway, so NOAA, great organization, produces this wonderful, they've got algorithms that can tell you how much UV is falling on any spot on Earth, the wavelengths, the energy, everything else. And we've been using this for mapping blood pressure and showing how UV correlates with lower blood pressure. But I thought, well, look, could we do this looking at COVID? Because we have COVID deaths at county level, and we can calculate UV at county level. So I got together with the mathematical geographers here in Edinburgh. None of us ever, of course, meeting in person because it was lockdown and we were all sitting at home like this, chatting away. Now, to die of COVID, several things have to happen. You have to meet somebody with COVID. You have to get infected. You have to get sick. You have to, and then you have to die. So and all of those are separate steps and separate risk factors, affecting your likelihood of each of those steps in this pathway from being healthy American to dead American. There's a lot of steps in that pathway. But you can actually pick that apart. So your risks of meeting somebody with COVID and catching it depend on the population density. Well, you have population density at county level. Clearly, and the amount of COVID in the population. So clearly, if you were living in Manhattan in, was it 2020? February, March 2020, when it first arrived in the States, and you're shoved into the subway and half the people there are coughing and hacking with COVID, you are surrounded by COVID. If you're living in, I don't know, North Dakota, driving your what do they call them, utes, you're driving your truck around, you meet a person a week, wave at them through the windows, and there's no COVID. So clearly very different risk factors. But the data is there. So you could calculate population density, percentage of the population who have COVID, public transport use, great where people meeting. So you can put that calculation into your model. So that's your risks of catching COVID. You then need to look at your risks of dying from COVID. And we know that there are several demographic factors which alter your risks of dying of COVID. So ethnicity is one. Darker skinned people had higher death rates. Age is another. Poverty is another. Air pollution is another. And all of that data is there and available. So you can put your second correction factor which is to correct for your chances, having acquired COVID, of dying of COVID. And the third thing that happens is In New England, everyone wears a mask because it's a sign of being a good citizen. And Louisiana, I'm generalizing, and I apologize for all those exceptions. In Louisiana, nobody wears a mask because it's a sign of the devil. You have these huge, I'm afraid to say, political, cultural differences in America.
Mm-hmm.
You also have at state level different policies, Florida imposing very different policies to, I don't know, New York and so on. So you put in a third random correction factor, which just corrects for kind of differences. Now, I am not a mathematical modeler. The code and the mathematics of this are far beyond me, which is why we simple dermatologists are good at making friends with people that can do the hard number crunching. But you can put in this model and you can build it up. And so what we then did was we collated and we cross-matched the deaths in the first 3 months of the COVID pandemic in America. So I think it was January to April of 20. And we could plot UV at each of these counties versus deaths from COVID, having done these really extensive corrections for confounders. And the final thing we did, I should say, is we excluded from our analysis the 20% of American counties where enough short wavelength UVB, was falling to make vitamin D. So we wanted to show an effect of sunlight independent of vitamin D, because sunlight makes vitamin D, but not all sunlight makes vitamin D. It's only the short wavelength UVB. And what happens as light comes through the atmosphere is that the more atmosphere it comes out, first of all, it reduces overall sunlight. But secondly, it particularly removes the shorter wavelength UV. So in Scotland, where I live, up at 56 degrees north, there is no UVB to make vitamin D for 6 months of the year, because that short wavelength UV is just removed from the atmosphere. And only really for the 3 months either side of June do we get enough short wavelength UV to make vitamin D. Whereas if you live down in the bottom of Florida, you can make vitamin D all year long because it's so far south. So we looked at these counties and this NOAA data, and we excluded from the analysis those southern counties where vitamin D would be formed.
I see. So you're asking, what's the relationship between your outcome with respect to COVID and the amount of UV you're getting if there is not enough UV around for vitamin D synthesis? Yeah. So you want to look at an effect that's independent of vitamin D.
Exactly. So there's a sunlight, not vitamin D effect. And what we showed really quite clearly was that there was a straight line dose-dependent relationship. The more UV, I can't say that you were exposed to, because we don't know what people were doing, but the more UV in your county, the lower the risk of dying from COVID. So we did that for America, great. But we then thought, well, that's great, let's do it again. So we then went to Italy, and we did it in Italy. And we then went to England, not Britain, which includes Scotland, but we went to England, and we did it for England. Now, and long story short, each of those countries, we found exactly the same relationship. We had to repeat the analysis for each country because the way we collate ethnicity, age, the geographical units in which we collect that data are different in England and different in Italy. So it was two independent and separate studies. However, they all showed the same thing. So the more UV where you live, the less the risk of death from COVID. So we sent this into an American journal, PNAS, and I have to stop fuming. Who went, no, this is fantastic. We love it, really interesting. And they sat on it for 6 months and then changed their minds. And the science is fine, but it's not very interesting. Having sat on it for 6 months, that God, I was pissed. We were anyway. An American group, by the way, from Harvard, did a similar analysis, a lovely analysis, which they did publish in PNS. They submitted at the same time as us. So they looked at growth in cases of COVID around the world, and they looked at northern and southern hemisphere countries, and they looked at growth in rates of COVID, and they looked at UV and humidity and temperature. And what was great there was the southern hemisphere is turning to winter as the northern hemisphere is turning to summer. So, it was a rather nice sort of... and what they showed was that the more UV there was, the lower the growth in COVID cases, but that temperature and humidity had no effect. So this American group and we showed less growth in COVID and less deaths from COVID.
And that temperature and humidity did not have an effect. That's interesting to me, because I was about to ask, how much of this do we think could be light exposure per se versus, how much of this is just an artifact of people spending more time outside in lower density environments when there's more sunlight around.
Yeah.
But the fact that temperature doesn't correlate would suggest that that might not be the case.
Yeah, I mean, really good question. And of course, always the fallback to epidemiology studies is confounders. What are the independent factors? A confounder, a factor which is independently associated with the exposure and the outcome. It is a behavioral due to temperature. So absolutely right, which you need to think about. Well, so what you need to do to prove it, to confirm it, is to then do an interventional study. And there's an American company called Cytokines, who then ran a super pilot study down in New Orleans year before last. And they took patients being admitted to New Orleans, the University Hospital there, with COVID. And they ran a randomized, placebo-controlled, double-blinded clinical trial. So, the kind of gold standard proper trial, giving UV phototherapy to half the patients who came in and giving a sham control to the other. Now, to be admitted into the trial, you had to have proven COVID. You had to be sick, as in your oxygen levels had to be below 94%. So that's, kind of sick, but not on intensive care. So you had to be sick, but not moribund. And, by the time 300 patients come in, you're sieved, by the time you kind of shiv down inclusion criteria, exclusion criteria, consent given, they ended up with 30 patients. So 15 got UV phototherapy and 15 got control. And those that were in the active group had the standard American Academy of Dermatology, because, of course, dermatologists use UV phototherapy all the time to treat our patients. We're either telling our patients don't go in the sun, or we're saying, can I give you some sun to cure your psoriasis and eczema? We're funny people. And anyway, so we have these standard protocols for giving UV, this evil stuff, to patients to make them better. So they gave 15 of them and of the 15 that were given UV phototherapy, 2 of the 15 died. Of the 15 who got the sham, 5 of the 15 died. Now, it's not big enough to be significant, but it's moving where you expect it to move.
And was that UVA only? Was it UVA and UVB?
No, interesting. It was UVB. And, a lot of my research, my cardiovascular research in particular, we've used UVA because it doesn't make vitamin D. And I've been keen to show vitamin D independent mechanisms of benefit of sunlight. Because dermatologists have grudgingly accepted that sunlight might have some small benefits. And paraphrasing, the sort of dermatology advice has been live in a cave, take vitamin D supplements. Those aren't the exact words, but that's the kind of broadly the kind of feeling behind it. Because we know that vitamin D, 100 years ago, again, dramatically, when rickets, osteomalacia caused by vitamin D deficiency, caused by either poor diet or lack of sunlight, led to rickets, a huge problem 100 years ago. And that was dramatically cured when, first of all, cod liver oil contains lots of vitamin D came along, and then vitamin D tablets. So this kind of, this amazing, one of the first wonder drugs. And the problem is we haven't really moved beyond where we were 100 years ago, saying UV causes skin cancer. Thank you, George Findlay. And vitamin D stops rickets. Vitamin D made by sun, terribly good for you. And we've kind of got stuck there for 100 years without moving it on.
I want to dig into vitamin D and skin for sure. Let's put a bow though on the COVID stuff. So where do we stand with respect to sunlight, UV, and COVID? What would you say the overall summary is in terms of where?
So I think the overall summary is there is epidemiology that in areas with more sunlight there is less COVID death. That tells you nothing about the mechanism. Is this an action of UV on airborne COVID virus? I think probably important part of it. Or is it an effect on UV on us? An effect on arming our innate immune system, for instance. We know that UV activates the innate immune system, and that's part of our defense against viruses. We also know, which we'll move on to, that UV mobilizes nitric oxide from stores in the skin into the systemic circulation. Now, NO, Nobel Prize for Medicine back in 1998, is this very important chemical messenger. It's a gas, it's a chemical messenger. It's responsible for lots of the cardiovascular benefits of sunshine. But we also have fairly good evidence that NO prevents SARS-CoV, the virus that causes COVID, SARS-CoV-2. It prevents its action. So the first bit of evidence is when the first SARS-CoV virus came along. I want to call it SARS-CoV-1, but it was called SARS-CoV because they didn't know there was a bigger and badder brother coming along later. So when SARS-CoV arrived about 5 years ago, there was some really nice work showing that nitric oxide binds to it prevents the post-translational modifications that are required for the virus to bind to the ACE2 receptor. So if you expose SARS-CoV to NO, the myristylation which is needed stops it binding to that ACE2 receptor. It has since been shown that NO also prevents SARS-CoV-2. It's the spike protein that sticks out of SARS-CoV is what it binds to the receptor with. And it shows that NO prevents the myristylation taking place, allowing SARS-CoV-2 to bind to the ACE2 receptor. And there are several clinical trials underway of using nitric oxide to treat COVID. And some of the early data is coming back showing promise for NO. And sunlight releases NO from the circulation. So there's a number of mechanisms by which sunlight might be reducing these cases and deaths from COVID.
I see. So
we're working on that now.
Yeah, there's plausible mechanisms there that they're candidates for how this could be sunlight per se, rather than some indirect effect.
Yes. I'd say, and of course, at the moment, what Cytokine are working on is getting the sort of backing to do a bigger trial on phototherapy to treat COVID, because the thing about phototherapy, we use phototherapy. This is a treatment which has been around since the 60s. We've had phototherapy for 60 years. It's safe, inexpensive, easy to administer. Almost, whatever the mechanism, we have the treatment. So, we can work on the mechanism, of course, important to know. But we have the treatment available now. It's just a matter really of amplifying up this small pilot study into a larger trial of the use of UV for that. So I suppose you were asking me about infection, and this is really taking us full circle to here we have an example of an infectious disease, the data is good for for sunlight helping us. Oh, and I should quickly come back to vitamin D. Lots and lots of observational studies showing that people with higher vitamin D levels are less likely to die of COVID. 2 big clinical trials, both published in the British Medical Journal in the last 2 months. One study was using cod liver oil to treat patients with COVID. The other large study, and these are randomized, double-blind, placebo-controlled clinical trials, the kind of gold standards, was giving vitamin D supplements, and neither study showed benefits from oral vitamin D in preventing COVID. And yet we have the observational stuff that people with higher vitamin D levels measured are less likely to die. And of course, a measured vitamin D level is a marker of sunlight exposure.
I see. So the correlation there could be sunlight exposure. Vitamin D is just a marker of it, even though vitamin D doesn't have anything itself potentially to do with this trend. Well, the other question I was eventually going to ask you is there a difference between vitamin D supplementation or from the diet, exogenous vitamin D, and the endogenously produced vitamin D in the skin?
So yes, so vitamin D3. So the dietary vitamin D, we have plant-derived vitamin D, ergosterol D2, and we have animal-derived vitamin D, and that the vitamin D we produce, vitamin D3. Always the importance when considering vitamin D studies, there's endless headlines, vitamin D stops this, vitamin D stops that. You have to pick apart the observational studies from the interventional studies. Mm-hmm. So if you measure people's vitamin D levels, and look at associated diseases with those, so we know that people with high measured vitamin D levels are less likely to have heart disease, less likely to have strokes, less likely to have diabetes, less likely to have rickets, less likely to have
cancer. So this would be D3 measured inside
D3, of a person. Yeah, measured in you. So your D3 measured in you. The problem is, so all of those observational studies correlating high measured vitamin D3 with less disease are not proof of causation. Correlation does not equal causation, Rule 101 of epidemiology. And there have been a mass of studies of vitamin D supplementation on health outcomes. And the biggest one is the VITAL study run in America. And this really wrapped up about 2 years ago. So 25,000 middle-aged Americans were given oral vitamin D supplements. So were randomized into this trial. Half were given vitamin D supplements for 5 years, and half were given a sham placebo control. And the results are coming out. And if you've got cancer, vitamin D supplementation seems to prevent it progressing. But in terms of heart disease, strokes, blood pressure, diabetes, no effect whatsoever.
And
in fact,
in
New England,
is this D3 that they're giving or D2? Exactly what is it?
I cannot remember. I think it was, I'd have to look at the papers, D3, open access papers, New England Journal, but a New England Journal editorial about July of last year. So 30% of Americans over the age of 60 take vitamin D supplements. And the New England Journal editorial rounded off, stop it. We have no proven benefits for a multiplicity of these diseases. Obviously, it's important in certain cases. Osteoporosis, rickets, we know it does, prevents progression of cancer. But a lot of those associations, it's not the vitamin D driving the reduction in disease. So we need to look again.
So how much, on the subject of vitamin D, animals produce D3, plants produce D2. There's this connection between UV and vitamin D in the skin that pretty much everyone has heard about. How much is being produced? Do we get most of it from the diet, most of it from skin production? How does that break down?
Well, a lot of it, I suppose it depends where you live. So if you live in Scotland in winter, none of it's coming from sun. If you live in Florida, most of it's coming from the sun.
I see. So it can go in either direction depending on environment.
And the other thing that matters is skin color. So what we know is that if you have darker skin, you need more UV. So, for a given amount of UV, there is a lower rise in UV-driven vitamin D in people with darker skin. And this may well have been one of the drivers to pale skin as humans move to high latitude, because one of the benefits of pale skin is that in a low light environment, you make more vitamin D. You make more vitamin D despite the low light. So that is one of the benefits. And also just using vitamin D as a kind of biological marker of response to UV it shows that biological processes driven by UV, those we know about, like vitamin D and nitric oxide release, occur better in low light environments. And I'm sure the same applies to the mechanisms we haven't yet discovered. UV driven mechanisms, pale skin favors those in a low light environment. And presumably that is what has driven this repeated evolution of pale skin in low light environments.
There's probably, I guess the idea would be there's probably multiple physiological effects of UV, which the body can use for good, healthy functioning. And vitamin D is one of them, but the lighter your skin is, maybe the more generally sensitive to these physical stimulators you are.
Yeah. And there's then some really good epidemiology confirming that. So, a friend and colleague of mine, Pelle Lindqvist, over at the Karolinska in Sweden, has analyzed the data from a wonderful study called the Melanoma in Southern Sweden study. So this is a study that was started in 1990, and they recruited 30,000 middle-aged Swedish women. It was actually a quarter of the population of middle-aged Swedish women. And and they wanted to find out how much UV leads to melanoma, and how does that kill people. So they recruited those 30,000 people, and they asked them 4 key questions about sunlight exposure. So do they sunbathe in summer? Do they sunbathe in winter? Bizarre in Sweden, but they're bizarre people, and some of them do. Do they go on foreign holidays? And do they use sunbeds? Now, clearly, there are lots of confounders associated with that. If you go on foreign holidays, you're richer, so you're probably better educated, so you're less likely to smoke, etc., etc., etc. But they went in great detail and corrected for all those confounders. So they asked about, education level, income. In Sweden, everyone's tax return is published openly on the same day every year. If you want to find out what your neighbor earns, you can look it up every year, or the prime minister. It's an open publication. So they checked, health records. Did they have diabetes, health problems, marital status, alcohol, tobacco? They went in and corrected for all these confounders. And they then went back 25 years later to find out who got melanoma and who died. And so you had a score broadly of 0 to 4, depending on your sunlight exposure habits. And what they found after correcting for all of these confounders was that those people that got the most sunlight, first of all, they got more melanoma on average, that there was more melanoma in the group that got more sunlight. However, the group that got more sunlight were half as likely to be dead as those dermatological...
All-cause mortality?
All-cause mortality. They were half as likely to be dead, all-cause mortality, as those dermatological goody two-shoes who avoided the sun altogether.